Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of systemic lupus erythematosus in children. We will cover 15 carefully designed clinical cases exploring the full spectrum of pediatric lupus, including clinical presentation, dermatologic and musculoskeletal manifestations, neuropsychiatric involvement, pathophysiology, diagnostic criteria, autoantibody workup, lupus nephritis, treatment strategies, and long-term complications including avascular necrosis, cardiovascular risk, and antiphospholipid syndrome. Let us begin. Case 1. A 12-year-old girl presents with a 3-week history of intermittent fever, joint pain in multiple joints, malar rash worsening after sun exposure, and fatigue with mild shortness of breath on exertion. On examination, she has a butterfly-shaped erythematous rash over the cheeks and nasal bridge, sparing the nasolabial folds. What is the most likely initial diagnosis? Option A, viral exanthem. Option B, rheumatic fever. Option C, systemic lupus erythematosus. Option D, juvenile idiopathic arthritis. The correct answer is option C, systemic lupus erythematosus. This 12-year-old girl presents with the hallmark triad of pediatric lupus: butterfly malar rash worsening with sun exposure, polyarthritis, and constitutional symptoms including fever and fatigue. The rash distribution sparing the nasolabial folds is pathognomonic for acute cutaneous lupus. Multisystem involvement in a young female strongly favors lupus over viral exanthem, rheumatic fever, or juvenile idiopathic arthritis. Pediatric lupus tends to present more acutely and with more severe organ involvement than adult-onset disease, making early recognition critical. Case 2. A 13-year-old girl with a known history of autoimmune disease presents for routine follow-up. On examination of the scalp, the physician identifies a raised, scaly plaque with follicular plugging and central atrophy. The lesion is well demarcated, located on the vertex of the scalp, and associated with localized hair loss in the affected area. There is no active infection or recent medication change reported. What is the most likely diagnosis for this scalp lesion? Option A, seborrheic dermatitis. Option B, discoid lupus erythematosus. Option C, folliculitis. Option D, photosensitivity reaction. The correct answer is option B, discoid lupus erythematosus. Discoid lupus erythematosus is a chronic cutaneous form of lupus. Lesions are raised, scaly, hyperkeratotic plaques with follicular plugging. Central atrophy and scarring alopecia occur when the scalp is involved, and unlike the malar rash, discoid lupus erythematosus lesions are scarring and persistent. They are found on sun-exposed areas including the scalp, face, ears, and neck. Seborrheic dermatitis causes greasy flakes without scarring. Folliculitis is pustular and infectious, and photosensitivity reactions do not produce follicular plugging or atrophy. Case 3. A 14-year-old girl has a 6-month history of progressive joint swelling in the wrists and knees. She reports morning stiffness lasting more than 1 hour. She denies trauma or recent infection. Labs show antinuclear antibody positive and anti-double-stranded deoxyribonucleic acid positive. Examination reveals bilateral wrist and knee swelling with reduced range of motion. Which physical finding best supports inflammatory arthritis over mechanical joint pain? Option A, crepitus on movement. Option B, pain relieved by rest. Option C, mechanical locking of the joint. Option D, morning stiffness lasting more than 1 hour. The correct answer is option D, morning stiffness lasting more than 1 hour. Inflammatory arthritis causes synovial inflammation that peaks overnight during inactivity, leading to stiffness that lasts more than 1 hour and improves with movement. Mechanical joint pain typically causes stiffness lasting less than 30 minutes, worsening with activity and relieved by rest. In pediatric lupus, synovitis with joint warmth, swelling, and prolonged morning stiffness distinguishes it from non-inflammatory causes. The key clinical pearl is morning stiffness greater than 1 hour equals inflammatory disease until proven otherwise. Case 4. A 10-year-old boy presents with pleuritic chest pain and dry cough for 2 weeks. Vital signs show low-grade fever, mild fast breathing, and oxygen saturation of 96% on room air. Examination reveals decreased breath, sounds bilaterally at the bases, and dullness to percussion at both lung bases. Investigations show bilateral pleural effusions on chest X-ray, antinuclear antibody positive at 1 to 640, complete blood count with mild anemia and lymphopenia, and markedly elevated erythrocyte sedimentation rate. What is the most likely underlying cause of these findings in this child with suspected lupus? Option A, pleuritis due to immune complex deposition. Option B, tuberculosis. Option C, pulmonary embolism. Option D, bacterial pneumonia. The correct answer is option A, pleuritis due to immune complex deposition. In pediatric lupus, pleuritis is the most common cause of pleural effusions, resulting from immune complex deposition along the pleural membrane. This triggers complement activation and local inflammation, causing fluid accumulation in the pleural space. Bilateral pleural effusions combined with pleuritic chest pain and low-grade fever form the classic sericitis triad in lupus. Tuberculosis is usually unilateral with upper lobe involvement. Pulmonary embolism causes sudden breathlessness without fever, and bacterial pneumonia typically shows lobar consolidation rather than bilateral effusions. Case 5. A 9-year-old boy with no prior medical history presents with recurrent episodes of severe headache, progressive confusion over the past month, and one episode of generalized tonic-clonic seizure. Additional findings include new-onset proteinuria on urinalysis, hematuria detected on dipstick, no recent infection or fever, and no family history of neurological disease. Which of the following clinical features is most suggestive of neuropsychiatric lupus in this context? Option A, normal electroencephalogram. Option B, low erythrocyte sedimentation rate. Option C, focal neurological deficit. Option D, negative antinuclear antibody. The correct answer is option C, focal neurological deficit. Focal neurological deficit is the hallmark feature pointing specifically to central nervous system involvement in lupus, distinguishing neuropsychiatric lupus from other systemic manifestations. While antinuclear antibody positivity, elevated creatinine, and thrombocytopenia may all be present in lupus, none of these specifically localize to the central nervous system. Focal deficits such as hemiparesis, aphasia, or cranial nerve palsies indicate direct neurological injury. Neuropsychiatric lupus occurs in up to 40% of pediatric lupus patients and carries significant morbidity. Magnetic resonance imaging with diffusion-weighted imaging is the first-line imaging in any child with lupus and new neurological symptoms. Case 6. A 13-year-old girl is newly diagnosed with lupus after presenting with malar rash, arthralgias, and persistent fatigue for 8 weeks. Labs show high-titer anti-double-stranded deoxyribonucleic acid and anti-Smith antibodies, low C3 and C4 complement levels, and mild proteinuria on urinalysis. Which immunologic mechanism is primarily responsible for tissue damage in pediatric lupus? Option A, immunoglobulin E-mediated allergic reaction. Option B, deposition of immune complexes in glomeruli and vessel walls. Option C, T-cell deficiency causing immune suppression. Option D, excessive interleukin-10 production by regulatory T cells. The correct answer is option B, deposition of immune complexes in glomeruli and vessel walls. In pediatric lupus, polyclonal B-cell activation produces autoantibodies, particularly anti-double-stranded deoxyribonucleic acid and anti-Smith antibodies, that bind nuclear antigens to form circulating immune complexes. These complexes deposit in the walls of glomeruli, small vessels, and synovium, triggering the classical complement pathway and recruiting neutrophils. This is the hallmark of type 3 hypersensitivity. The result is chronic inflammation, endothelial injury, and progressive organ damage, which explains the multi-system nature of lupus. Case 7. A 13-year-old girl with known lupus is admitted during a disease flare. She has facial swelling, frothy urine, and generalized fatigue for 2 weeks. Examination shows periorbital edema, mild hypertension, and a faint malar rash. Labs reveal markedly decreased serum C3 and C4, elevated anti-double-stranded deoxyribonucleic acid, and urinalysis with 3+ protein and red blood cells. Which component of the complement cascade is most commonly consumed first during immune complex-mediated inflammation in lupus? Option A, C1q. Option B, C5a. Option C, C9. Option D, factor D. The correct answer is option A, C1q. C1q is the first recognition molecule of the classical complement pathway. It binds directly to immunoglobulin G or immunoglobulin M antibodies within immune complexes. This triggers the activation cascade, C1R, then C1s, then C4, then C2, then C3, culminating in membrane attack complex formation. In pediatric lupus, low C3 and C4 reflect ongoing C1q, initiated complement consumption, which is a key marker of active disease and lupus nephritis flares. C3 and C4 levels are routinely monitored to assess disease activity and treatment response. Case 8. A 14-year-old girl presents with a 3-month history of facial rash consistent with malar distribution, urinalysis showing proteinuria greater than 500 milligrams per day, positive anti-double-stranded deoxyribonucleic acid antibodies, and complete blood count revealing thrombocytopenia with platelets of 68,000 per microliter. According to the 2019 European League Against Rheumatism and American College of Rheumatology criteria, which combination of findings meets the threshold of 10 or more points required to classify this patient as having lupus? Option A, fever only. Option B, antinuclear antibody negative, no further criteria met. Option C, malar rash only. Option D, proteinuria plus anti-double-stranded deoxyribonucleic acid antibodies plus thrombocytopenia. The correct answer is option D, proteinuria plus anti-double-stranded deoxyribonucleic acid antibodies plus thrombocytopenia. Using the 2019 classification criteria, proteinuria greater than 500 milligrams per day scores 3 points in the renal domain. Anti-double-stranded deoxyribonucleic acid antibodies score 3 points in the immunology domain. Thrombocytopenia below 100,000 per liter scores 4 points in the hematology domain. The total is 3 plus 3 plus 4, equaling 10 points, which meets the classification threshold. Importantly, a positive antinuclear antibody is required as the entry criterion before any scoring begins. Case 9. A 10-year-old boy is referred for evaluation of suspected autoimmune condition after recurrent joint pains and mild fatigue over 4 months. Examination shows no malar rash, no oral ulcers, mild bilateral wrist tenderness, no lymphadenopathy, and no organomegaly. Investigations so far: antinuclear antibody positive at high titer, anti-double-stranded deoxyribonucleic acid negative, anti-Smith antibodies negative, and no renal or neurological symptoms reported. What is the most appropriate next step in the diagnostic evaluation of this child? Option A, stop the diagnostic workup. Antinuclear antibody alone is sufficient for diagnosis. Option B, evaluate for antiphospholipid antibodies and complement levels. Option C, perform a skin biopsy immediately. Option D, initiate hydroxychloroquine therapy without further testing. The correct answer is option B, evaluate for antiphospholipid antibodies and complement levels. A positive antinuclear antibody is highly sensitive but not specific for lupus. In the absence of anti-double-stranded deoxyribonucleic acid and anti-Smith antibodies, further evaluation is mandatory. Testing for lupus anticoagulant, anticardiolipin immunoglobulin G and immunoglobulin M, and anti-beta-2 glycoprotein 1 antibodies identifies patients at risk for thrombosis, even without renal or neurologic symptoms. Low C3 and C4 suggest active classical pathway consumption and guide diagnosis and monitoring over time. Never stop the workup at a positive antinuclear antibody alone. Case 10. A 13-year-old girl with known lupus presents with 3 weeks of progressive puffiness around the eyes, foamy urine, and decreased urine output. On examination, blood pressure is elevated, with mild periorbital and leg edema. She appears pale and fatigued. Laboratory results show low serum albumin, markedly decreased C3 and C4, elevated anti-double-stranded deoxyribonucleic acid titers, and urine dipstick with 3+ protein and blood present. Which of the following laboratory findings is most indicative of active glomerular disease in this patient? Option A, high-low-density lipoprotein cholesterol. Option B, low erythrocyte sedimentation rate. Option C, normal serum creatinine. Option D, urinary sediment with red blood cell casts. The correct answer is option D, urinary sediment with red blood cell casts. Red blood cell casts indicate glomerular bleeding, specifically blood entering the tubules from inflamed glomeruli. They are highly specific for active glomerulonephritis and are not seen in simple urinary tract infection or proteinuria alone. In lupus, this signals immune complex deposition in the glomerular basement membrane. Active urinary sediment with red blood cell casts plus proteinuria in a child with lupus warrants urgent renal biopsy to classify the nephritis and guide immunosuppressive therapy. The most severe form is Class 4 diffuse proliferative nephritis. Case 11. A 13-year-old girl with known lupus presents with significant facial and lower limb edema, frothy urine for 2 weeks, and blood pressure elevated at 148/96 millimeters of mercury. Urine protein is 3.8 grams per day. Serum creatinine is elevated. Urine sediment shows red blood cell casts. Anti-double-stranded deoxyribonucleic acid is strongly positive, and C3 and C4 are markedly low. Renal biopsy confirms Class 4 lupus nephritis with a diffuse proliferative pattern. Which of the following is the most appropriate induction therapy for this patient? Option A, ibuprofen. Option B, methotrexate. Option C, intravenous methylprednisolone plus mycophenolate mofetil. Option D, hydroxychloroquine monotherapy. The correct answer is option C, intravenous methylprednisolone plus mycophenolate mofetil. Class for lupus nephritis is the diffuse proliferative form and the most severe class, requiring aggressive induction therapy to rapidly suppress inflammation and preserve renal function. Intravenous methylprednisolone provides immediate high-dose anti-inflammatory effect. Mycophenolate mofetil has replaced cyclophosphamide as the preferred induction agent in children due to equal efficacy and better safety profile. Hydroxychloroquine continues as background therapy throughout all phases. The maintenance phase uses mycophenolate mofetil or azathioprine with low-dose oral prednisone taper, monitored with urine protein, creatinine, and complement levels. Case 12. A 14-year-old boy with known lupus presents with persistent hemolytic anemia, with critically low hemoglobin despite treatment, high-dose oral corticosteroids ongoing for several weeks with inadequate response, and Coombs-positive hemolysis confirming autoimmune etiology. Standard therapy has failed, and the team is considering escalation to biologic therapy. Which biologic agent is most appropriate for this patient based on current evidence? Option A, rituximab. Option B, infliximab. Option C, tocilizumab. Option D, etanercept. The correct answer is option A, rituximab. Rituximab is a monoclonal antibody targeting the CD20 receptor on B cells, depleting autoreactive B cells and reducing autoantibody production. It works through antibody-dependent cellular cytotoxicity, complement-dependent cytotoxicity, and direct apoptosis. Rituximab is reserved for refractory cases, particularly refractory hematologic manifestations, including hemolytic anemia and thrombocytopenia, and is preferred over belimumab in this setting. Important monitoring parameters after rituximab include complete blood count, immunoglobulin levels, and infection risk, including hypogammaglobulinemia and infusion reactions. Case 13. A 16-year-old girl with systemic lupus erythematosus has been on high-dose prednisone therapy for 18 months to control severe disease activity. She presents to the emergency department with sudden onset of severe bilateral hip pain and difficulty walking. The pain began yesterday after getting up from a chair and has progressively worsened. She denies any recent trauma or falls. On examination, she has limited range of motion in both hips and significant pain with internal rotation. What is the most likely complication responsible for these findings? Option A, septic arthritis. Option B, osteoporosis with compression fracture. Option C, avascular necrosis. Option D, growth plate fracture. The correct answer is option C, avascular necrosis. Avascular necrosis occurs in up to 25% of pediatric lupus patients over time and is most commonly caused by long-term corticosteroid use. Steroids impair microvascular blood flow to the femoral head, resulting in bone ischemia, structural collapse, and hip pain. Bilateral hip involvement is characteristic in lupus-related avascular necrosis. Septic arthritis is typically unilateral with fever and elevated inflammatory markers, and osteoporosis causes fracture risk rather than femoral head signal loss on magnetic resonance imaging. Magnetic resonance imaging is the gold standard for early avascular necrosis detection before X-ray changes appear. Case 14. A 12-year-old boy with a 2-year history of systemic lupus erythematosus presents for routine follow-up. He has been on long-term corticosteroid therapy and hydroxychloroquine. Recent labs reveal elevated low-density lipoprotein cholesterol, and he is noted to have persistent hypertension on 2 separate visits. Doppler ultrasound of the carotid arteries shows increased intima media thickness bilaterally. Which of the following is the most likely underlying mechanism responsible for his accelerated cardiovascular risk? Option A, lack of exercise. Option B, chronic inflammation leading to endothelial dysfunction. Option C, high sugar intake. Option D, vitamin D deficiency. The correct answer is option B, chronic inflammation leading to endothelial dysfunction. Children with lupus are at significantly increased risk for premature atherosclerosis due to chronic systemic inflammation, immune complex deposition, and endothelial damage. This accelerated cardiovascular risk begins early in childhood and is amplified by both traditional factors such as hypertension, dyslipidemia, and corticosteroid use, and lupus-specific factors including antiphospholipid antibodies, complement consumption, and accelerated vascular aging. Carotid intima media thickness is a validated surrogate marker for early atherosclerosis. Regular cardiovascular risk assessment should begin at lupus diagnosis, including lipid monitoring and blood pressure surveillance. Case 15. A 15-year-old girl with known lupus presents with sudden onset of left-sided weakness and slurred speech developing over 2 hours. She has been on hydroxychloroquine for 18 months with no prior cardiac history and no recent infections or trauma. Examination shows right hemiparesis, mild expressive aphasia, and facial asymmetry. Blood pressure is mildly elevated. Magnetic resonance imaging of the brain confirms acute ischemic stroke in the right middle cerebral artery territory. Anti-double-stranded deoxyribonucleic acid is positive. Platelet count is borderline low at 110,000 per microliter. Which of the following tests is most specific for diagnosing antiphospholipid syndrome in this clinical context? Option A, false positive venereal disease research laboratory test. Option B, bleeding time. Option C, platelet count. Option D, anti-beta 2 glycoprotein 1 antibody immunoglobulin G. The correct answer is option D, anti-beta 2 glycoprotein 1 antibody immunoglobulin G. Anti-beta 2 glycoprotein 1 immunoglobulin G is the most specific antibody for antiphospholipid syndrome. In pediatric lupus, antiphospholipid syndrome is a secondary complication causing thrombosis and stroke. Lupus anticoagulant is sensitive but less specific, and anticardiolipin can be positive in infections. Anti-beta 2 glycoprotein 1 immunoglobulin G must be positive on 2 occasions at least 12 weeks apart to confirm antiphospholipid syndrome diagnosis. Management includes long-term anticoagulation with warfarin targeting an international normalized ratio of 2.5 to 3.5 for arterial thrombosis, plus hydroxychloroquine to reduce thrombotic risk. Before we wrap up, we would like to tell you about our Patreon community, Pediatric Case Review. This community brings together all our lecture videos organized by body system, so you can easily find, revisit, and study every topic in one organized space. In addition, every presentation used in our videos is available as high-resolution photo slides, so you can read through the cases and practice all questions at your own pace. If you would like to join and get full details on how to subscribe, simply comment below on this post, and we will message you directly with everything you need to know. This brings us to the end of our lecture on systemic lupus erythematosus in children. We covered 15 cases spanning clinical presentation, dermatologic and musculoskeletal findings, neuropsychiatric lupus, pathophysiology, diagnostic criteria, autoantibody evaluation, lupus nephritis, induction therapy, refractory disease, avascular necrosis, cardiovascular risk, and antiphospholipid syndrome. The key takeaways are: early recognition of multi-system involvement is critical. The 2019 Classification Criteria Guide accurate diagnosis. Lupus nephritis requires prompt aggressive induction therapy, and long-term monitoring for complications is essential. If you found this lecture helpful, please follow Pediatric Case Review for more informative presentations. If you have any questions, drop them in the comments below. We read every single one